You can go live now.
Good evening to all the delegates and our eminent speaker. Thank you all for joining this evening. I am Siddhant Sharma on behalf of Hetero Healthcare. Welcome you on behalf of webinar on the introduction to Bempedoic Acid, non-statin lipid-lowering agent in the management of uncontrolled LDL-C. As you know, lifestyle disease in our country is on rise and it's surprisingly moving towards a chronic stage. We at Hetero Healthcare has always been at forefront along with your side to deal with such ailment. This evening, our esteemed and experienced doctor will share their clinical experience on the subject. Before proceeding further, do let me take the privilege to introduce our eminent panelist. Dr. Mahesh Shah, he is a senior interventional cardiologist. He is attached to Hindujak Hospital, Arogya Nidhi, as well as BSCS Hospital. He is the faculty at many national as well as international meetings. His main interest lies in the complex coronary, carotid, and aortic interventions. He is a principal investigator in many clinical trials. Also, he has many publications in the name of national and international journals. Also glad to introduce our second panelist, Dr. Kapil Rathi. A warm welcome to you on the scientific talk. Dr. Kapil is having 14 years of clinical experience and a vast experience of treating 1,200 COVID-19 patients. He has undergone specialized training in diabetology, cardiology, and critical care from various reputed national and international institutes. He is an active member of Kurla Suburban Doctors Association, Andheri Parle Physician Association, and various other medical bodies present in India and abroad. He is also a co-investigator for various clinical trials and surveys conducted by Indian and multinational companies. So I welcome Dr. Mahesh Shah and invite him to take over the session.
Thank you, Siddhant. I'll start sharing my slides first. And here we go. All right. Thank you, Siddhant, for the kind introduction and today's opportunity, Hetero. Thank you all participants to be with us. This is a new kid in the block in terms of management of dyslipidemia, and it was something which was really needed. Let's see how we can go through the story to build up this molecule, its exact place into the therapeutic armamentarium against the fight against ASCVD via dyslipidemia. Dyslipidemia, friends, we all know, has a major impact on cardiovascular morbidity and mortality. The burden of dyslipidemia is huge. Even among younger population, in urban population, almost 30%, and in rural population, almost 15% of the people have some kind of dyslipidemia, and prevention and treatment of dyslipidemia is very much essential. We all know that LDL is necessary and sufficient cause for ASCVD. We have multiple risk factors for ASCVD like diabetes, hypertension, dyslipidemia, smoking, etc. But if somebody does not have LDL, somebody's LDL is in 20s and 30s, right from early childhood, probably irrespective of any other risk factors, the likelihood of him getting ASCVD is very, very remote. So it is necessary and sufficient. Suppose your LDL is 200, 250, 300, and you don't have any other risk factor, LDL alone can give rise to ASCVD. So it's a necessary and sufficient risk factor. Other risk factor increase or decrease the probability when they are combined with dyslipidemia, but they are neither necessary nor sufficient for this. So this statement is very important, and hence LDL is the most important target in fight against ASCVD. In 30 to 40 years of age, dyslipidemia incidence is quite high and it keeps on rising. When we are born, the LDL is something around 35 or 40. And by the time we reach the age of 20, 30, it has a tendency to go up to 100, 120, 130, etc. And nowadays, there is a consensus developing that in early adulthood, when your LDLs are in 120s and 130s, by late adulthood, by the age of 40, 50, 60, you get ASCVD, and there is a legacy effect of those early exposure. There is also a concept of lifetime exposure to LDL coming up, wherein in earlier life, how many years, what LDL level you have been exposed to, that determines your subsequent risk of ASCVD, and hence the importance of reducing your LDL right at the earlier age, even in primary prevention and seemingly normal LDL levels like 100s and 130s. Particularly in India, because we are at a high risk of developing ASCVD at an earlier age, either by genetics or by atherogenic diabetic dyslipidemia, or through exposure to variety of inflammatory stimuli like recurrent infection, inflammation, environmental pollution, smoking, stress, and whatnot. And 2/3 of deaths due to non-communicable disease in India are cardiovascular related. So it's number one killer, and almost 2/3 of all known causes of death, non-communicable causes of death, are because of cardiovascular disease. The normal lipid levels we are not going to go through. Now let us see what are the challenges and gaps in the lipid management as of now. We have come a long way. Statins and n number of statins, low intensity statin, moderate intensity, high intensity statins. We have had phenomenal number of trials, phenomenal number of patient years of experience of using statins. They are so prevalent that practically every patient knows about statin. But still, we are quite far away from the ideal management of cholesterol. So what are the challenges and gaps in the current dyslipidemia management? Many patients with hypercholesteremia remain above guideline despite the current treatment of maximally tolerated statin therapy, particularly because our guidelines, our levels, recommended levels or our targets of LDL have been dropping. Decades back, it was 130. Then we came to 100 LDL level was the target. Then it came that diabetic and secondary prevention after an MI or ASCVD, you should go down to 70. Now we have gone it down to 55. And then we have defined very high risk and extreme risk categories wherein our LDL targets are 40, and the Lipid Association of India goes to the extent of recommending 30 in very select subgroup of patients who have an extreme high risk. To fight this high LDL and to bring down to lower and lower, tighter and tighter, difficult and more difficult LDL targets, practically we have only two things, that is high intensity statins and ezetimibe. The capacity of high intensity statin is 50-55% reduction in LDL, and ezetimibe gives rise to additional 10, 12, 15% LDL reduction. And despite both being used, there are significant number of patients who are not able to achieve the target which is there for them, and thereby they have a residual cardiovascular event risk. And that cardiovascular risk is clearly related to your cholesterol levels, and if you can bring it down, nothing like that. Now, what all other medicines we have available, and their mechanism of action. Number one is our statins. They act at the liver, HMG-CoAs enzyme inhibitor, and that is the rate limiting step in cholesterol synthesis. Cholesterol absorption inhibitor ezetimibe acts at the intestinal level. Bile acid binding resins, they act inside the intestines and prevent the absorption. They bind to the LDL, and LDL gets excreted instead of enterohepatic circulation, and it gets excreted. Thereby, it reduces the dietary intake of LDL. PCSK9 inhibitor act again at the liver level, and that leads to more absorption of the LDL, increasing the LDL receptors. Fibrates, they do not primarily act on LDL. Niacin also does not act primarily. They primarily act on triglyceride levels, but modest effect on LDL are found through variety of mechanism depicted over here. The kid in the block today, the point of discussion is acyl cyclase lyase inhibitor, that is bempedoic acid, which reduces cholesterol by its action on hepatic ACL enzyme. And when ACL enzyme gets blocked, ACL enzyme works into the cholesterol synthesis pathway 2 steps above the HMG-CoAs where the statins act. So it acts upstream, not downstream, upstream of the statin metabolism, and it has been found to give rise to additional LDL reduction on top of high intensity statin. Let us see what all evidence do we have. 80% of the patients who are on statin, they do not achieve your LDL targets, either because the statins are ineffective to bring down LDL level. Somebody who started with an LDL of 90, high intensity statin can bring it down 190. It can bring it down to something around 90, 95, 100, which is still high. You add ezetimibe, another 15% reduction, it will still come down to 80, 85. And that is far away from the target of certain group of patients where we expect the target to be 30s and 40s. So something more is required. On top of that, certain number of patients, they have side effects, either muscle, liver, or induction of diabetes, new onset diabetes or worsening of diabetes. And hence you may not be able to use statin either at all, or you may not be able to achieve higher dose and strengths which are required. So that would limit the amount of LDL reduction which can happen. And then there are certain number of patients who are not adherent to statin, thanks to a lot of anti-statin lobby on social media, which contributes to this anti-statin feelings in certain patients. So because of these things, we need to have certain molecule, a new molecule which does not carry this baggage of side effects, public perception, or lack of efficacy in very low targets in very high HDL levels. So residual risk is one, non-attainment of LDL targets, and non-adherence. These are the challenges with the statin therapy. Statin intolerance, either liver, muscle, or diabetes related side effect, and hence the need for an additional control. And for that additional control, we have a new molecule, which is bempedoic acid. We are going to discuss PK, PD, and a lot of things about that bempedoic acid in next few slides. Kapil, feel free at any point if you want to discuss anything, or if you want to give your input for the benefit of the audience.
No, I think we till now we are going great. Once you finish up, then we will have a discussion.
Sure, no problems. So it's a ACL inhibitor. It's an oral tablet, 180 milligram, has to be given once a day. It is rapidly absorbed from the small intestine, and it is unaffected by food. So you can give it in the morning, you can give it in the evening, you can give it before meal, after meal. You have a lot of freedom, so you have a lot of flexibility. The effect lasts for 15 to 24 hours. 99% plasma protein binding is there, and it is converted to active metabolite. Ultimately, 70% gets excreted in the urine, and 30% gets excreted in the feces. So dual mode of elimination is there, and that gives you a freedom that sometimes if you have hepatic dysfunction or renal dysfunction, the other mode will get activated more, and you will not have a too much buildup of the levels. Now, the major differentiator between bempedoic acid and the statins is their effect on muscle. Now, bempedoic acid is a prodrug, needs to be converted to bempedoyl coenzyme A, and this is the active molecule which really acts. And that happens through acyl-CoA synthetase 1 or ACSVL1. Now, ACSVL1 is present only in liver and kidneys. It is not there in muscles. So that prevents the conversion of citrate to acetyl-CoA, and acetyl-CoA then gets converted to HMG-CoA, where statins work, and then ultimately it leads to the formation of cholesterol. So statins would work at this level, and bempedoic acid will work 2 steps above. And the active conversion from bempedoic acid to the active molecule occurs only in liver and kidney. It doesn't happen in muscle, and hence you do not expect muscle-related side effect with that particular molecule. This slide represents more or less the same thing. Bempedoic acid through ASCVL1 gets converted into an active drug, which prevents the further pathway of cholesterol biosynthesis. When the hepatic LDL comes down, LDL receptor upregulation occurs, and that clears more and more LDL from the blood, thereby reducing the LDL. And despite it acting into the same pathway two steps above the statin, it does cause an additional LDL reduction on top of statin therapy. And since it does not get converted to active molecule into the skeletal muscle, you don't expect skeletal muscle related side effects. Muscle weakness, adherence, etc. are likely to be better. This molecule was approved in itself, bempedoic acid, and in combination with ezetimibe somewhere in February 2020 in USA, and USA bempedoic acid as well as ezetimibe fixed drug combinations are available. The approved indication is heterozygous familial hypercholesterolemia. These are typically the guys whose LDLs are in 200s and above, like 190 and above, and hence achieving the target even in primary prevention patients where targets are not very low is very difficult. And in patients with established ASCVD who do not tolerate statin or who do not achieve the target despite taking high intensity statin. These are few of the indications. Even in primary prevention, when your targets are not achieved, your particular LDL target, you can always replace it with a bempedoic acid, or you can add it on. Not only LDL comes down, even ApoB comes down. It has gotten significant anti-inflammatory activity. High sensitivity C-reactive protein comes down. HSCRP levels go down by almost 40%. And there is a significant reduction in LDL. How much it occurs in the different clinical scenarios, we are going to discuss. What happened to my share screen? It stopped sharing. All right. On top of statin, you can expect an additional LDL reduction by 22%, and it is safe and effective on top of the standard statin therapy. Indications we have already discussed: heterozygous hypercholesterolemia or ASCVD patients where you are not able to achieve the target, or the patient does not tolerate the statin therapy. There are few side effects like tendon rupture, and which occurs more if the patients are on simvastatin, pravastatin, or if they are on fluoroquinolones, etc. People who have CKD. There are few of the cautions which are required, which we are going to see in certain other slides. Pregnancy, like any other new molecule, we do not have any trials because no ethical committee gives you a permission to do a trial in pregnancy, lactation, and pediatric use. So we do not have any data in this, but off-label usages people have been doing. It's not recommended. Adverse reaction are practically like placebo. Almost less than 2% adverse reactions are non-specific, like URTI, muscle spasm, hyperuricemia, back pain, abdominal pain, bronchitis, etc. Very non-specific side effects. Uric acid has a tendency to go up if the patient has had a history of gout. Periodically, you might check uric acid. Routine uric acid checking is not really required. And what are the clinical data we have? Let's have a couple of slides on that. We have a significant number of data. There is a group of trials known as CLEAR, CLEAR SERENITY, CLEAR Wisdom, CLEAR Harmony, and CLEAR Tranquility. And then we have a meta-analysis or group analysis in hypercholesterolemia patient and in patients with diabetes. CLEAR SERENITY trial was in statin intolerant patients requiring lipid lowering therapy for primary or secondary prevention, and that showed bempedoic acid was safe, well tolerated, and muscle related symptoms were in 4.7%, which was equivalent to patients on placebo. Clear Harmony trial was in patients with hypercholesterolemia who were already on statin therapy and they were not on target. 742 patients, 52-week trial was there, and it when added to maximally tolerated statin therapy, there was no increased incidence of major side effects with additional significant lipid lowering. Clear Wisdom trial, it was in patients at high severe risk on maximally tolerated lipid therapy, more or less similar kind of findings. And Real Tranquility, again on background of statin therapy or statin intolerance. Let's see if you combine the results of all those trials, Clear study snapshot, if you can see, in the patients who had persistent hypercholesterolemia, despite maximally tolerated statin therapy, there was an almost 15 to 16% additional reduction on LDL. This is in patients who are on high dose statin therapy. And what about patients who were statin naive, patients who were not taking statin? In that case, we had almost 24% reduction in LDL. So this is the amount of benefit you expect. The patients who are on lipid therapy, on top of that, you use as a combination, you expect around 16% reduction. If the patients were statin naive, they could not tolerate any statin, you can expect something like 23-24% reduction. These trials were a significant number of patients were there, 2,500, 700, 300, 200, and things like that on maximally tolerated statin or very low or no statin background therapy. So practically the garden variety of patients which we see routinely in our day-to-day clinical practice, they were represented in these trials. The key point in prescription needs to be kept in mind: mild to moderate renal impairment, no dose adjustments, end-stage renal disease, no data, better to avoid. Mild to moderate hepatic failure, no adjustment needed. Severe hepatic failure, chart plug class C, don't use it. The patients who already had a prior history of gout or very high uric acid, periodically you might check it or treat hyperuricemia clinically, but patients who had recurrent gouts or gout frequency goes up, you may not use this. Patients above the age of 60 who are on steroids, who are on fluoroquinolones, who have a renal failure, or who have a prior history of tendon rupture, particularly Achilles tendon rupture, a precaution is required. Try and avoid in those group of patients where multiple of these factors are there. This is a very peculiar side effect. The exact mechanism is not known, but it is worth noting it down that people who are on this group of medicines, etc., a caution is required. And if the tendon rupture occurs, you might have to remove the therapy. Patients who are taking simvastatin or pravastatin more than 20 or 40 milligram, think of changing them to higher intensity statins. Practically, simva and prava we do not use in our area. We use rosuvastatin, atorvastatin, and occasionally pitavastatin. Pregnancy and breastfeeding always remains a caution for any new molecule. In patients with hypercholesterolemia, phase 3 randomized controlled trials, pooled analysis, almost 1,200 patients, and you can see there was a significant change in LDL levels, 16% and 23% in patients who are not on statin or patients who are already receiving statins. And when added to maximally tolerated dose of statin, including moderate or high intensity statin therapy on background, were associated with an additional LDL reduction without increased incidence of side effects. And in diabetic patients, particularly, we would like to know whether it leads to worsening. 3,621 patients followed up for up to 52 weeks. And here you can see glycemic parameters, whether patient was diabetic, pre-diabetic, or normoglycemic. Glycemic parameters did not change significantly. So was the fasting blood sugar as compared to placebo. There was no worsening of glycemic variables, which is a concern in patients with statin. Almost 10% of the patients can develop glycemic variability related issues. So to conclude, friends, it's a new kid in the block of lipid lowering therapy. by inhibiting ACL enzyme in the liver 2 step above the statin pathway, above where the statins are involved. It can be given with the maximal tolerated of statins or statins plus ezetimibe without any increased incidence of side effect, but additional 15 to 24% reduction in the LDL can be achieved. It reduces apolipoprotein B, HCRP, does not affect the muscle side effect, does not cause increased incidence of glycemic issues. With that, I hope I have made all basic issues clear. Whatever is left out, I have my experienced colleague, Dr. Kapil Rathi, and we would be happy to discuss any points or questions which come. Kapil, over to you for your comments.
Sir, I think, sir, thank you, Etro, and thank you, sir, for that excellent presentation. I think you have covered most of the point what we as a physician or as a practicing doctor want to think. Whenever something new comes up, we always try to say कि हमको ये क्यों change करना, why we need to change, or why we need this because. And of late, because primarily we were not noticing a lot of, not many side effects, but a bit of side effect with statin because there was nothing available, and which was available was quite costly, like PCS9. So now here comes something called as PC, the ACL inhibitor or Bempedoic acid. So suddenly we find out, in our practice also, a lot of patients who are not tolerant or where we cannot go up, on the dose part, suddenly we require something, and Bempedoic acid is, helping us out. Now, my only 2-3, points or rather than questions to you, sir, is a lot of people means people who don't understand the data, or the people who just want to try it out, they will try it out upfrontly without starting statin. So I just want you to make it very clear that statin still remains the drug of choice for hypercholesteremia or dyslipidemia. Bempedoic acid is on top of what is going on. So it is statin first. If it is not tolerated, or if it is not been given for some or other reason, then comes Bempedoic acid, not either way, not the other way rather than. So that is something which I want you to tell to our audience how we should go about, because now we have got a lot of platter with us of ezetimibe, Bempedoic, PCSK and all other. So how we go about in a patient who is like probably a moderate risk patient who comes to you for the first time, and then he asks, sir, आपके पास में दोनों तीनों, how should we go about that?
Well, statins are a giant so far as dyslipidemia management is concerned. The amount of data, the amount of number of patients treated, number of trials in variety of different clinical situations is phenomenal. On top of that, the clinical endpoint trials are there. Statins not only reduce LDL, but they reduce infarct, stroke, death, arrhythmias, and whatnot. With Bempedoic acid, we have only the surrogate endpoints, that is LDL, HSCRP, HbA1c, and things like that. We still need to have the data. It's very clear that it is to be given in patients on top of statin if your targets are not achieved. That's number one. Number two, targets are achieved, but patient does not tolerate high intensity statin, doesn't tolerate 40 milligram, he tolerates only 2.5, 5 or 10 milligram of rosuvastatin or similar quantities of atorvastatin. Then you will be forced to use either ezetimibe or Bempedoic acid or both to achieve your targets. And the third is patient who doesn't want to take it, patient who is kind of mentally you just simply cannot convince him about statin. These are the times when you really want to use Bempedoic acid. My crystal ball gazing says that young patient and the moderate risk, probably in future, this might become the molecule of choice, because very young patient and a moderate risk, they are not at a very high risk. Suppose in 20s and 30s, if you want to use it, you would like to use a molecule which over long years does not cause any long-term consequences, particularly diabetes. We know that statin, despite causing diabetes, saves lives. But if something can come without the burden of diabetes, we would like to prefer. And that's why in one of my slides, I had made a comment that early age primary prevention, probably we need a molecule which is absolutely safe in the long term. So that is where probably there could be a use for using Bempedoic acid alone. Now there are a few more questions there are a few more questions. How frequently do you check lipid profile after starting bempedoic acid? Kapil, would you like to answer that?
I don't know. So I think the protocol remains same as it for statin. That is what we do. So it is not that you give it and you check it after say, 2 weeks or 3 weeks. Generally, what we do is basically I do basically after 3 to 6 months of after starting on a bempedoic acid or for that matter any dyslipidemic agent. So that is what I do. What is your take on this, sir?
Primarily, the maximal effect of bempedoic acid you can see within 6 weeks time. So anything after 6 weeks, between 6 to 12 weeks, you can check it to find out what is the efficacy and whether you have been able to achieve your targets. So within 6 to 12 weeks, I would recommend that you can check to find out how much effective it is. Another question is how much time the patient can be given bempedoic acid, how long to give. There is a very common misconception that डॉक्टर साहब आपने दिया था ये गोली कोलेस्ट्रॉल का 3 महीना हुआ, हमने कोलेस्ट्रॉल चेक किया, कोलेस्ट्रॉल इससे क्योर हो गया था और हमने not only that, in tier 2 tier 3 cities when you go for non-allopathic doctors, many a times there is a misconception and they just give a 3 or 6 month course of therapy. So your comments on bempedoic acid, how long it should be given?
So I think, sir, means it goes without saying that these are all, these are probably, kind of a lifetime medication. So you don't stop it unless and until there is a compelling indication to stop it, basically. Otherwise, and especially for bempedoic acid, looking at all the data, probably without practically quite safe drug, vis-a-vis statin, where you need to monitor certain things, or patient might come up with some or other side effect. So probably once I start, I'll take it, regularly with your lipid profiles and everything, and I'll try to keep my numbers, what I want to target, and probably I'll give it till the time the patient is tolerating, rather than going by the patient's will. It will be pure on the scientific basis what we want to achieve our targets, and probably lifetime. That is what I think.
8 out of 10 of my patients, when I say you have to take lifelong therapy, do not like it. So I do not give lifelong statins. Now ask me, what do I do?
Yeah.
I tell them that, okay, there is a formula, 100 minus your age, that many years you take the statin. So if you are 40 years, take it only for 60 years, don't take it lifelong.
Correct.
I said, सचिन का सेंचुरी हो जाए बाद में वो कैसे भी बॉल उछाले, कैच हो गया, आउट हो गया, doesn't matter. Up to 100 years of age, you take care properly. So rather than giving them lifetime, when I give them joke, they understand and they don't argue much. So that's the way I tell them. All right. There's one more question. How do you handle bempedoic acid in patients with CKD? It was already discussed in the slides, but still there is a question, and let's discuss it again.
Yeah, so I think, sir, till I think CKD stage 3 or till the eGFR is 45, I don't think there's an issue with bempedoic acid. Below 45, it's always better, as we do with statin and other stuff also. So probably it's same category bempedoic acid fall. So till 45 eGFR, I'm happy to give it 180 milligram. If it is go less than 45 ml GFR, then probably you have to cut down dose, or you have to think of something else if you are not able to tolerate bempedoic acid. But otherwise, till mild renal impairment, I think it is very well given in the data, in the books, and as well as all the data is what they say is that because it is 70-30 excretion pattern through urine and feces, I think it will work very well till 45. After that, you have to be a little more cautious and even reducing the dose or changing the drug.
Absolutely, I fully agree. And still, if you are pushed to the wall, patient is already on statin and ezetimibe, and still you have to give, you can go down off-label indication up to maybe 30 or even 20 eGFR. But in those cases, be more observant about the potential side effects, potential for effect, etc. So these are the places where a caution is required. Above 45, you can safely go ahead. The treatment protocol for lipid profile for dose adjustments. Treatment protocol, my friend, classically, every 6 weeks, we would keep on checking if the patient came with an ASCVD or first time I have seen the patient, put put him on an appropriate dose of statin, high intensity or moderate statin intensity as per the guideline recommendation. Check it at the end of 6 or 8 weeks. If you have not achieved the target, step up the dose of statin. If you still do not achieve the target on maximally tolerated statin, then you add either ezetimibe or bempedoic acid as the case may be. And if the patient cannot achieve with 2 molecules, then you add the third. Previously, you have used bempedoic acid, then you use ezetimibe, and previously, if you have used ezetimibe, you use bempedoic acid. PCSK9 inhibitor goes into very high-risk patients, but unfortunately, that is going to make your patient poorer by 35,000 rupees a month with a discounted therapy and an injection with a lot of skin-related injection site-related side effects in almost 10, 15, 20% of the patients. But it's a beautiful molecule. It gives rise to 60% additional LDL reduction on top of statin. Now, this question is specifically only you are qualified to answer, Dr. Kapil. Any post-COVID complication in lipid profile observed? What is the effect of COVID, long COVID? What happens to lipid profile after COVID? Have you had any observations? I have not come across any data.
We have seen there is no print data, but yes, what we have seen in a patient, the problem is that you don't get a new dyslipidemic too much, but you get a lot of dearranged lipid profile who were already dyslipidemic or who were very well controlled initially, and suddenly after COVID, their LDL and other things go haywire because of probably stress induced, drug induced, and probably the lifestyle. There is a long COVID means you are almost out for 3 to 6 months. You're absolutely at home, and you are depressed and eating more or whatever. So these are all things which have there because of the long COVID. We have definitely see the sugars as well as the cholesterol are getting a little bad after long COVID or post COVID, but we are not getting new cases. Yes, we are getting new diabetic patients, and diabetic dyslipidemia we are seeing a bit, but not very very high number of patients who are going to get dyslipidemic immediately post COVID. No, but yes, you can get the disturbed lipid profile after a long COVID, which is much more. And there probably I think because this patient have a lot of body ache and everything, so post COVID my one of the favorite drug, if the patient is suffering from dyslipidemia, probably will be bempedoic acid, because this a lot of otherwise cramps and other things are there with the patient, a lot of myalgias and arthralgias which are there post COVID. We don't want anything which will aggravate that, so probably there bempedoic acid is a good choice according to me.
Yeah, and particularly my concern is long COVID patients, they'll have a lot of inflammation.
Yeah.
Because it's an inflammatory disease. And there is a lot of tendency for clotting. It's a pro-coagulant, pro-inflammatory disease, and both are covariants to precipitate to progress both ASCVD as well as precipitate acute coronary syndrome. So these are the group of patients where I would definitely be a little more aggressive as compared to general primary and secondary prevention patients. And bempedoic acid will come in very handy because of the lack of muscle-related side effects. Of course, this is all experience and expert opinion based. There are no guidelines or data on this. And I don't think as clinician we can wait for those guidelines and data in post-COVID patients.
Yeah.
With that, I think majority of questions from the audience are over. If you want to...
There are a couple of points which I want to make, sir, and which I want you to be answering. That is, one advantage with bempedoic acid is that you don't have to worry too much about dose, which we have to worry about. A lot of people forget what is moderate intensity, what is high intensity, and a lot of people give baby doses, 5 milligrams of atorvastatin and all over. So there are so many things which happens in clinical practice. What we see, you must be seeing a lot of prescriptions where you just feel ki boss kya de rahe ho. So that is what is happening. So with the bempedoic acid, at least one thing is sure, that it is only one strength, 180 milligram, and that will go in. So that way you are sure that your patient is taking right dose rather than miffling around the doses. So what is your take on this, sir? That is a good option actually.
So there are a lot of fringe benefits with this molecule as compared to statins. Number one, it's a fixed single dose. There is no much of clinical complexity. So a primary care physician would find it very comfortable and acceptable. There is not much of monitoring required, like hepatic enzymes and muscle enzymes and things like that. You don't have to worry about that. You don't have to worry much about the renal parameters or hepatic parameters as far as mild to moderate hepatic or renal dysfunction is concerned. So it's a very clinician-friendly molecule. And I'm sure it can be more easily acceptable. Plus, there is no social media anti-molecule kind of sentiments created. So that also would make it very convenient. You know, some patients would say, "Sab isme steroid to nahi hai na." Statins, beta blockers, etc. are, badnam molecules without any reason. This one has got an advantage that, it's a clean phase.
Yeah. And the second question, sir, probably the last one, are you going to check uric acid of every patient before you start bempedoic acid? And if yes, then when you will do the repeat uric acid once you start bempedoic acid?
Gout as a side effect is not necessarily a very serious kind of side effect. Uric acid practically gets measured in all our patients, and nowadays with a lot of online pathologists, etc., majority of patient comes with that $1,500 worth of package where everything is measured. Specifically, I don't check uric acid in any of these patients, but to tell you frankly, 95 out of 100 of my patients would have their previous uric acid levels in their file sometime or other. So practically speaking, if somebody does not have history of gout, you don't need to check uric acid upfront before starting therapy. And after starting therapy, you don't need to check it periodically unless the patient has a history of gout. If they develop gout, anyway, it can be treated very easily on an OPD basis without much of the cost or without much of the consequences, and it can be taken care of. We just warn the patient if they get any muscle gout-related symptoms, they get back to us at an early stage rather than beating around the bush.
Yeah, I think that is how practically we also go. And the last thing, food for the thought, whether it will be good to have a 20 milligram rosuvastatin plus 180 milligram bempedoic acid in one tablet. So that will have that, the blanket therapy mostly. Most of our patient will fit into that category.
My take on this is something different. It may not be economically very much viable for the company, but according to me, all those gold preparations, 10 and 20 milligram, are good for nothing. All ezetimibe combination therapy, 10 and 20 milligram, are good for nothing. And all bempedoic acid combination with statin, 10 and 20 milligram rosuvastatin, are going to be good for nothing. Because either you give bempedoic acid alone in patients who do not tolerate any statin, or on maximally tolerated statin, you would like to utilize the statin benefit, which is clinically proven, clinical endpoint based proven. On top of that, you should give. If I was a drug controller, and if I was taking the interview of these people when they want to come with the new data, new trial, new permissions, I would say you first come with 40-180. 20-180 is your optional.
Yeah.
Because people have a tendency to use lower dose even where higher dosages are tolerated. Now, somebody who has been on 40 milligram of rosuvastatin, his LDL is still 65, and I want his LDL to be 55. I'll have a kind of incentive to use combination 20-180, and I will be doing injustice to the patient. I'll be treating him suboptimally, though he is tolerating statin, just because this combination is available and others are not available. So I am very aggressive in dyslipidemia management. 40 plus 180 should be the first combination. 20-180 only in a guy who does not tolerate 40. But economically, it will make better sense 20-180 because majority of clinicians would be comfortable with 20 milligram. That's what I observe in my clinical practice.
Yeah, possibly. So I think we have discussed in length and breadth about clinical scenarios, not use of bempedoic acid, and how do we practically apply in our practice. So I think we are done with from my end, and from hetero end. If there are any more questions, then we'll be happy to answer. Otherwise, I'll give it back to hetero.
Yes, doctor, I think all the answers you have covered so far. So yes, doctor, it was indeed a pleasure and honor having you doing this webinar. We, on the behalf of Hetero Healthcare, would like to extend our sincere thanks to you for your comprehensive session, and we are sure our delegates would got enlightened regarding the molecule, as we have covered all the possible aspects in your session. Also, we would like to extend our thanks to all the delegates for their warm presence. Thank you so much for joining, doctor. It was nice meeting you.
Thank you, everyone. Bye-bye.
Bye, sir. Bye.